request now Tulsi, who's chief of Lions Arvind Lions Arvind Institute of Community Ophthalmology. I have requested him to talk what is the lesson from combating cataract backlog in India, the Arvind experience, and how to extrapolate for diabetic retinopathy screening and prevention of diabetic blindness. Because I had when I had a discussion, I thought he has got a spark which nobody has utilized it, and I thought even Kim has not utilized it. So I thought let the AOS utilize it so that it will go to the entire country. And if the country progresses, I think the South America and Africa also will follow. Thank you. And with this, Tulsi, request you to give your talk.
Thank you, Natarajan. Hope you can see the slide.
Yes.
Okay, fine. Yeah.
Yes,
So before I jump into the topic, I just wanted to reiterate that as far as the government goes, I think they are on board, for supporting diabetic retinopathy. In fact, I think they've also made, if you look at the pattern of assistance, they also have allocated some funding per treatment kind of a mode. But somehow we haven't really utilized it to the extent that we are utilizing for cataract surgery. So I think to some extent we have to get our act together before we can go back to the government again to enhance the support. So that's one part. So let me get on to what Dr. Natarajan requested me to do, basically to share lessons from cataract program. Yeah. Yes. Yes.
No. What you mentioned? No, what you just mentioned as a preamble that government is already on board.
Yeah.
And Namrata and Rajesh and all of us were telling we want to government. So what is that is lacking, and we are not, as an ophthalmologist or a thing, we have not used it. Maybe we can have a mail from you later, and then I think we will work with the AOS to go to the government and tell the doctor that we have not done this, and let all our members do it.
I'll do that. Yeah, I'll do that. In fact, I think my presentation is also somewhat in that vein, to talk about that. So I'll certainly cover that. Yeah. And I'm going to be presenting not so much what Arvind did for cataract, but I think more as a national program, how we went about it and how come that succeeded. I think the context is the cataract surgical rate in India is around 6,000 plus. Now, which is sort of comparable to more advanced or more developed countries. And then when you compare with other developing countries, including China or rest of Asia, they're kind of probably around 30–40% of India's performance. So in a lot of the global meetings, now India stands little head high and proud in terms of the eye care services because of the achievement, largely in cataract, because that's the only thing that's getting measured. So before we go further, I thought it would be good to understand the two paradigms, of managing cataract versus managing diabetic retinopathy. So it'll be good if Parikshit could mute. We are hearing the traffic noise. Thanks, Parikshit. Yeah. So when it comes to cataract, I think this was mentioned, the patient are able to sort of self-diagnose. They know when they're elderly, and we notice this in eye camps. Now, when a cataract patient comes to an eye camp and we tell him, you have to come with us, to the base hospital for surgery, they're ready. They've already come with the bag and everything. So they seem to know that the condition they have and it requires surgery and so on. While with diabetic retinopathy, like it was mentioned by Dr. Nam, it is asymptomatic, and we need to depend upon the referral by specialists and others. So there is this notion of a middleman, that comes in when it comes to diabetic retinopathy, and which creates a certain challenge by itself. And the goal in cataract is surgery, which will restore sight, while the goal in DR is more around prevention and preserving sight. This very fundamental difference, because in one, you are giving, suddenly it is like night and day. Without exception, everyone who gets a cataract surgery is so elated. And we can't say that about anyone who gets intervention for diabetic retinopathy. So So that's another important difference. So a cataract patient sees immediate benefit. Now, while a diabetic retinopathy patient, there is a potential benefit which they will never recognize. No, prevention is very difficult to appreciate. And then also in cataract, the patient's role is quite limited, other than accepting for surgery and then doing the post-op medication for those 3 or 4 weeks. Now, but in DR, patient's role is so critical because if they don't comply with the advice that we give, there is no way we can help them. Again, cataract is a short cycle intervention, probably 5-6 weeks. I'm starting with pre-op to final follow-up. While the DR, it's a lifelong care. And so with cataract, we can be reactive. That is, if a patient shows up, we deal with the patient, operate them. Because the patient can self-diagnose and recognize they have a fall in vision. But with DR, we need to be proactive because we are more in the prevention kind of a realm. So I'm just laying this high-level difference between the two things because we got to think very differently from cataract, even though many of the strategies that was followed in cataract program can apply here. So I'm kind of listing here what made the cataract program succeed in India. One, there was a massive awareness drive, which actually the government of India funded. There were many television programs, radio spots. I'm talking about the period from mid-1990s for about a decade or so, when we had the World Bank funding. A sizable amount of that money was used for creating awareness. So that's critical, especially for diabetic retinopathy, which is asymptomatic. Now, wherein even the medical community doesn't appreciate. We don't get that many referrals from physicians. There is a lot of community involvement in the cataract program, especially for outreach. A lot of it is organized by the community. And then we have a reasonably good case finding mechanism at primary level. Even volunteers can find cataract patients and bring them to camps or whatever. And then what we have done very well over the years, it was not the case early on. The cataract service delivery design closes the loop in the sense from case finding to enabling the patient by mobilization free, if they are not able to afford providing surgery and then follow up. Even the government subsidy of 2,000 rupees, which they give now, there are elements for case finding. The ASHA workers got to be paid so much. There is money put aside for feeding the patient and transporting the patient. There is funding for the surgery and follow-up. So the design inherently has become closing the loop, which enables the patient. So this was all one part on the demand side. Now, all of this enhances the demand for the service, which is probably the primary problem that we have with DR. And then there was a nationwide training and skill development in cataract surgery, especially when the technique shifted to ECCE and SICS. So many leading institutions were designated as the training centers, and the government supported literally thousands of people to be trained in the cataract surgery with IOL implant. And then every district had the capacity to do good cataract surgery. They all had A scans, microscopes, slit lamps, and all of that, as well as all this consumables that is required. And plus equally the non-government hospitals, private practitioners, NGO hospitals, all of them were available at a much more distributed level. And there was funding support. This was already highlighted by the government, by INGOs and charitable eye hospitals. And then we had lots of surveys done. We had lots of evidence around cataract services in terms of magnitude, how many people are blind, what is the surgical coverage, where are the gaps, what was the outcome. And this was fundamental, I think, because I think you need hard data to push policy. No, because like Dr. Namrata said, the big change happens when you're able to influence government with, and for that you require good data. I remember a conversation with Dr. Sujata Rao, because up to that point of time, the government of India was not supporting IOL surgery. Then I showed her the field data, wherein when we went to the field and looked at ICC operated patients, not that the surgery was bad, but more than 40% were blind in terms of by definition, because they didn't have the aphakia correction glasses. Now, while similar group with IOL implant, it was about 5 or 6%. So that's when she immediately changed and said, we cannot be doing this anymore. No? So we got into, so that's how the government came into the buy-in. So getting that evidence is important, which we don't have for DR in any measure. And then above all, I feel there are many champions for cataract surgery. So this is, I think, what made the government also move, and all of this happen. So now if we reflect, are these relevant for DR program? This is the exact same slide which I showed earlier. No, you would all agree that we need significant awareness drive. In fact, I would say more than what we did for cataract, because here it is asymptomatic, and even the middlemen, so-called middlemen, the physicians don't fully appreciate the role of eye and diabetes. We certainly would require community involvement. And then we also have to develop a mechanism for case finding at primary and community level. Because if you depend upon case finding only at retina clinics, then this is kind of already a non-starter. So we need to work on that. And then again, we need to figure out the way we did for cataract, make sure that every patient who is diagnosed to have DR, this whole service happens with minimum effort and financial burden to the patient, really enabling the patient to do that. And similarly, we also would need skill development, and we got to figure out what we mean by this. There was mention about people not being trained to take photographs. So there are all kinds of skills that need to be developed, and we need to do this not in a knee-jerk fashion, but in a very systematic, programmatic manner, doing it nationwide. And then make sure that people don't have to travel long distances to get treatment or to get periodic monitoring. And of course, the funding. And then we also have to start building evidence. What is the extent of diabetes, DR, with real data, not very broad numbers of 60 million, 80 million. I mean, that beyond a certain point, I think people just start ignoring it. But if we can start having granular data and of how many people are covered, etc., I think we can certainly move policy. And then here also, we require many more champions. And I'm not sure we have. I say this only because even though we have the government funding, we as providers have not really leveraged this in the case of DR. So what else do we need to enhance DR management? I think this came up, I think, in the discussion. I think we need to really explore integration with the general diabetes ecosystem, that is with physicians, laboratories, pharmacies. We also must really question who should own diabetic retinopathy. Because if we own it exclusively, others can't get in. Can we also make the physicians own the problem? As much as they own kidney or foot problems and things like that, can they also own the eyesight of the patients that they treat? Again, we need to really work much more on technologies, and I think Dr. Kim may be having some comments on this. Because I don't think it will be possible if the 65 million diabetes showed up in retina specialists. One, they won't show up. If they did, we just don't have enough retina specialists to deal with them. No, and I don't think we see 65 million patient visits even otherwise with all ophthalmologists put together. So we really need technologies which can remove the work from specialists much more into the grassroots to PHCs and that level. And then I think most importantly, we need to develop systems for chronic care management. This is my, I'm not an ophthalmologist, but as a person involved in eye care for 4 decades, I recognize that we are reasonably okay in episodic management, glasses or cataract surgery and so on. But then things like glaucoma, DR requires us to develop a system for systematically managing these chronic conditions. Things like having registry, which can document all patients with diabetes, whether they have had an exam or not. Creating support groups, peer support groups, so that there is some peer pressure to enhance compliance, having reminder systems. And then chronic care costs money, for the patient, and also a lot of effort. So we also have to be thinking about payment mechanisms and so on. And finally, I think above all, I believe it requires a different mindset, of all of us as providers. In the sense with cataract and glasses, we could be reactive. We could deal with, and then the dependence on the patient and others is very little. But here we have to become responsible for a whole lot of process, and engage in activities that today we traditionally don't do. Traditionally what we do is we deal with patients who come to us, and that we know is a very, very minimal number, especially for diabetic retinopathy. So we need to really figure out what do we do because what we do, if we keep doing it, I think we'll keep getting the same results. We won't solve the problem. So I think I fundamentally feel we need to start thinking very differently about this problem. Thank you.
Thank you, Tulsi. I think a wonderful revealing. Only the last slide, can you show again?
Sure.
The last slide, the one before. That's the homework. I think I wanted Rajalakshmi, Rajiv, and Kim to help me to make a note.
You're talking about this one, huh?
The last but one. The last but one.
Let me see. 1 minute, just 1 minute.
Go to thank you and one before.
This one.
No, next one.
This is the thank you one. I'm going back. This is
this one.
Back.
Yeah. So you said it requires a different mindset. No, that one is the same one. There are one before. Yes. So we have to back one for the whole process and engage in activity that we traditionally don't. I think this is what I learned from you when I met you in Madurai. So I think this is what I want this idea to be bought by everybody in the group here for taking this. And then how do we proceed further? As you rightly said, you're waiting for the patient to come. Patient doesn't have symptoms. I think even Shobha in our Ornate India, we have about 180 patients, I think, who are diagnosed with proliferative diabetic retinopathy. The doctors are ready to do free treatment, but the patient doesn't want to do it because he says, I don't have complaint. Why should I do a laser? So I think that's what you're saying, to have a different thing to do, get a different result. If you do the same, you will get the same result, and we'll keep the number of diabetics keep increasing. I think that's what is happening, right, Tulsi?
Yeah, that's exactly that. Yeah.
Yes. So I think I really, Dr. Kim, you want to say something? I know you're from Arvind, and what do you want to respond to Tulsi's talk? Kim and Rajiv.
One of the important thing is the onus. I've been talking about this on shifting the onus of case finding to the physician, because that's where the whole target population is. I think that's something very, very important. How we make sure that our doctor colleagues take up this responsibility of finding the case. Just like as he said, food, everything else they take care of of the diabetic complications except the eye complications. That's something that we should bring the change in that. And also the whole thing is about completing the loop. Very often it's not just case finding, but we also have to ensure that these patients are followed through. They have way to go, have a checkup, or if need, treatment to be available. So all these has to be a complete system should be available for them. Yeah, that's.
Yes. Thank you, Kim. And Dr. Rajiv?
It was a very good talk, and I was just wondering, each slide had so many pearls of wisdom. Each point is important. I think that all slides, if we can all get it, and we need to work on each one of them, because it is multiple things. You cannot just have one, exactly what Dr. Tulsiraj mentioned. And I think we have learned a lot from cataract, and the approach which you had thought, that how we can translate to DR. I think that is a very good thing, and lot of brainstorming on individual each point is needed, because we can talk about awareness, just see how cataract was done, what different here it is, and how to make it possible, where the funding comes from. So each point can be taken in much details, but I think thanks, sir, for giving such a nice way of comparing both, and I think that would be of tremendous help, and I think all of us should try working on these points.
Thanks, Rajiv. I'll be happy to share this with Dr. Natarajan, and we can share it with the group. Yeah,
I will do that, and thank you, Tulsi.